This is Digital Pathology Today. Now, here's your host, Dr. Joseph Anderson.
We keep hearing that one of the promises in digital pathology will be the ability to develop AI-based tools and algorithms that will allow us to do things we've never done before. This gets a lot of people excited in the industry, particularly computer scientists, programmers, and machine learning specialists. But what about the role of the pathologist? Will it be important to keep the pathologist engaged in the development of AI algorithms and digital pathology workflows? If so, why and to what extent? And is this realistic? One of the things that's hindered surgical pathology, or maybe just the perception of it, is a lack of standardization and reproducibility in terms of molecular testing, IHC testing, as well as the interpretation of good old-fashioned H&Es. Part of the promise of digital pathology, we hear, is that we can help eliminate this variability or subjectivity. But wouldn't pathologists developing their own algorithms recreate the same old problems? Welcome to Digital Pathology Today. I'm Joe Anderson. We're talking with Dr. Rish Pai, who is currently professor of laboratory medicine and pathology at the Mayo Clinic in Phoenix, Arizona. Dr. Pai has lectured nationally and internationally on many aspects of GI and hepatic pathology and has directed multiple GI and liver CME courses. He's past president of the Roger Hadgett GI Pathology Society. He is a regular reviewer for numerous pathology and gastroenterology journals and serves on the editorial board of the American Journal of Surgical Pathology. Dr. Pai has published over 130 articles and written multiple book chapters in the fields of GI and hepatic pathology. We're going to be talking about why it's important to keep the pathologist engaged in these new algorithms, what Dr. Pai's personal experience is in developing new algorithms. Was it a steep learning curve? Were there any surprises? What did he learn? Pathology is a unique specialty in terms of providing the definitive tissue-based diagnosis and purveying predictive and prognostic information that will become a part of the patient's treatment plan. What obligations do we have to provide input into the development of these algorithms, and what obligations will we have as the ultimate end users? Dr. Rish Pai, welcome to the podcast.
Thank you, Joe. It's great to be here. Glad you invited me.
Nice to have you on. I think we're going to delve into a fascinating topic today, talking about the development of AI algorithms and really how it impacts the pathologist with boots on the ground, so to speak. Because I think we're all aware we're coming up to this kind of inflection point where we're departing from the old ways of doing things, and we're going to be embarking on new ways, which I think most notably will incorporate algorithms and artificial intelligence. So I guess in the workflows, how we triage cases, how we decide which pathologists get to review which cases. And then secondly, predictive and prognostic algorithms. So how can we add prognostic information with the assistance of artificial intelligence and algorithms? So you have a unique perspective or a concern that we need to keep all of us pathologists engaged. What do you mean by that? And what does engagement mean, and why do you think that's important?
Yeah, no, it's a good question. So, when I first started getting into digital pathology, it's a disruptive technology. We all like looking, or at least I do. I like looking at my microscope. I'm used to it. The glass slides are there. It's, I'm a GI and liver pathologist, so looking at, tubular adenomas, it's a few seconds. So what can digital pathology add? And the more I thought about it, and the more I started using digital pathology, just realizing it's just another tool that pathologists have, just like immunohistochemistry, just like molecular tests, and we're the end users of it. So it's something that we just need to incorporate into our practice, whether we're using digital pathology just to review slides for conferences or for consultations, or we're using digital pathology for the more exciting stuff like applying AI algorithms, enhancing and augmenting our diagnoses. So that's kind of where, we're the end users, the people with boots on the grounds. And I think we have to engage with it, even if it's maybe uncomfortable to you or you're not as into the digital platform as people who live and breathe it. We're with digital pathology from the beginning. I think we're at the point now where just practicing pathologists day in and day out need to start engaging with digital pathology.
What comes to my mind is, with the adoption of any new technology, there's a kind of a curve, an adoption curve, where on one end you have the renegades, the mavericks, the early adopters, so to speak, and they're probably going to be very interested in being the first to use it, very interested in participating in developing the new tools. right? Then you have the massive middle, and then you have the laggards, right, who want no part of it.
Exactly.
Having worked, in various settings myself, I kind of entered that world where there's an IT department and programmers, or basically people who are not physicians, right? They're not the end user, but yet they have the technological savvy and know-how, and then ultimately design the tool. And there's kind of a goal for a chasm in the middle, right? Where you tell them what your requirements are, and then 6 months later they come back and say, well, here it is, knock yourself out. And I think there's a very high risk of the thing not working, or no, this isn't really what we really wanted. When I said we need to count the cells, I meant this. Or when I said we need to measure the nucleus, I meant this. I didn't mean that, right? So, how realistic is it for the pathologist to be involved and give that feedback?
I think it's almost not a question of is it realistic or not. It's almost like it needs to happen, right? Any tool that's going to end up used by pathologists has to have pathologist input. And I think it needs to start right from the beginning. And I think it is realistic. I think there's certainly a group of pathologists in the US that have been engaged with digital pathology from the beginning, but I think that needs to expand to everyday pathologists that are engaging and starting to use this. It's not that 100% of all surgical pathologists, because that's what I am. So that's what I'm talking about when I talk about pathologists. It's not that all of us need to be deep in the weeds on this, but there certainly needs to be a substantial percentage that are engaging with digital pathology, helping design algorithms, helping design software that we interface with. Because as you said, there's the IT kind of infrastructure, the kind of people in the back, and they don't maybe know exactly what we do and what we need on a day-to-day basis. For example, this is completely separate from AI, but just simply designing an appropriate mouse that we need to view these, or an appropriate system where we can move the slide around in a good way on a big screen. And so far, I haven't really seen a good product for that. And that's just dying to be developed. I played around with, Space Mouse and some of these other things, but just something like that, Joe. Just having the end user engaged, it's a necessity, even if it's hard.
Okay, yeah, that's interesting. You mentioned possibly about specialized tools just to suit the purpose of pathology, because those kind of tools are everywhere. Like there's video games that are the controllers are optimized, for playing that video game, or even in medicine. I remember when I was a medical student, I couldn't believe it that in surgery, right? I couldn't believe the specialized tools that they had in surgery just to do very specific tasks, right? So for like stapling up the colon, there was a specific tool, and there was another tool if you wanted to for an ileojejunostomy. So, and just the various retractors. So everything was very highly specialized. But for, I think so far, like you said, for digital pathology, we're just using the regular keyboard and mouse. So, where's all of our tools? Is that coming?
I just thinking about, you see the ads for those virtual, goggles that you put on. And, in some ways it's kind of, we want to recapitulate what a microscope looks like to us, but digitally. So, I have thought about that. I think it's actually space ripe for development. Although we're a small specialty, so to invest in that maybe is going to be difficult for some companies to do.
Yeah. Okay. Well, something to look forward to.
Yeah.
So I kind of like to play devil's advocate. So thinking about involving pathologists in developing these algorithms, two things that come into my mind. One is, in pathology, or probably in many fields, there's always been this kind of push-pull tension between centralized testing and local testing, in terms of developing the test, performing the test, being able to bill for the test. So I think a good paradigm is in breast cancer. We've been doing the prognostic markers, the ER/PR, HER2, Ki67 panel for many, many years, 30, 40 years. And it started off as a ligand binding assay, which had to be sent to a centralized lab because it was complicated. It involved radioactive material. You didn't want your technicians glowing in the dark and so on. But then came the advent of immunohistochemistry, and then those tests came back to being able to be performed locally in your own lab. And then now we have these fancy molecular tests like the Oncotype test or MammaPrint or other molecular assays, then back to the central lab. So there's always been kind of this push-pull tension. So similarly with algorithm development, is it going to be concentrated centrally, or is there going to be opportunity for pathologists to develop their own algorithms, or is it going to flow back and forth? How do you see that playing out?
Yeah, I think honestly it's going to be an all of the above kind of approach at the beginning. For example, I think there are certain algorithms that are relatively simple, right? That can be deployed, I think, in pretty much any pathology lab. Just quantification of, Ki-67, it's done down by traditional machine learning. It can be done, by deep learning. Those things probably can be deployed locally. But I think, more complex algorithms that integrate AI that requires a little bit more post-processing steps. So you run the algorithm, then you filter it through another step to generate, a prognostic score, or you integrate that AI algorithm with molecular tests. I think that's really exciting. Those kinds of things, I think, are going to require a little bit more involvement of a central site rather than deployed locally. So I do think it's going to end up being kind of all of the above approach with definitely some algorithms deployed locally, run by pathologists during their sign out. I think that would be really exciting. But then sort of more complex algorithms that require multiple processing steps, and particularly if they're integrated with other tests to come up with kind of a really overall kind of interpretation. I think that's going to require a little bit more centralized approach.
Okay. And one of the things that's hindered pathology, maybe just in perception or reality, is that there's human beings involved. And my grade 2 might not be your grade 2, and so on. So I think standardization, reproducibility has been a concern, particularly in H&E interpretation. And then also even in IHC, right? For the longest time, there really wasn't standard methods to do IHC. You might do it a slightly different way in your lab in terms of the antigen retrieval, which antibody are you using, what your cutoffs are for positive or negative. So, and now we have this promise, or at least the perception, that digital pathology is going to help us standardize things, particularly maybe looking at H&E images, right? So we're going to, instead of human beings counting things or human beings grading things, we're going to have an algorithm or image analysis is going to be able to standardize things. So large groups of patients are going to be able to be compared based on what this algorithm has shown. So this is great. But you, Dr. Pai, are saying, well, maybe we can all produce our own algorithms, or we can all we can all be involved. We can all be involved in the development of new algorithms. So aren't you undermining the great future that lies ahead of us?
It's a really, really good question. And I think you're absolutely right for certain algorithms. I think it's probably unrealistic to have, each, let's say, a breast algorithm developed by, a group of pathologists, and then, another group is developing. But I guess I would go back to, the use case. And for example, when the ground truth is pretty straightforward, right? When we all pretty much know it, and it's just the algorithm needs just a lot of the training on the various ground truths that are very established. I think in that situation, you don't really need to have, some specialized company or commercial product doing that. I think you could probably do that, locally. What I worry is that if we wait, so let me play the opposite question. Let's say we wait and we have these algorithms and we wait for various companies to develop them. Number one, that's going to take a long time. But number two, what are their goals, right? It's a bit maybe more financial driven than what are our goals? What are our needs as pathologists? For example, I developed an algorithm to count eosinophils in colon biopsies. Who's going to develop that? Why would a commercial entity be interested in that? I really do think it's going to be that all of the above kind of approach, which will bring in that you'll have multiple competing algorithms out there. But that's going to be true even if we wait for commercial entities or large academic institutions to develop them rather than, individuals.
Yeah, it is. I think it is certainly interesting on the leading edge of innovation. Like you said, there's going to be orphan diseases, so to speak, or areas where it wouldn't make financial sense for a company to develop algorithms, and so maybe kind of this grassroots approach may be useful. And interestingly, you coming from the Mayo Clinic, I think Mayo has kind of a history of trailblazing somewhat, especially in diagnostic pathology. The first the first paper on tumor grading was published by Mayo Clinic pathologist Eli Broder. And, I think at Mayo, you guys have been known for using some non-standard or 4-tiered grading system where the rest of the world was using, 3 tiers. So I certainly admire that spirit. So what about regulatory concerns? I think, at least in my mind, I kind of conceptualize this as a medical device where these algorithms developed are going to be medical devices and then distributed, by the various AI-based platform companies or maybe even the scanner companies, right? So that the pathologist can overlay this on their digital pathology system. The approval process would be FDA clearance or FDA approval, depending on the complexity. But I think talking to you, it sounds like we might also need to incorporate an LDT type approach where if we're developing algorithms in our own laboratory to suit a specific purpose, we might need to develop and validate this in a similar way as another laboratory developed test, or at least in surgical pathology, like maybe an IHC test that we bring up ourselves. So what do you think about that?
Yeah, I actually think the LDT approach is going to be one I think it's going to be a little bit easier pathway to implement some of these algorithms. I think the FDA process, and again, I'm not an expert. I've interacted with the agency in different contexts, and I think they're beginning to look at AI algorithms in a way that maybe will speed up the process. But I think that's going to take a long time, and that's something that I think even institutions, large institutions, are just uncertain of how to approach the FDA to get clearances. So I think an LDT model could actually work, because I think in the end of the day, when these algorithms are being deployed, there has to be a filter through a pathologist, right? The algorithm will run, the output will appear. If it's a simple one that you can interpret, right then and there, you're going to have the option to approve or not approve, just like we have the option to interpret IHC. So there's going to be that pathologist assessment of any output for most algorithms. So I think the LDT approach makes sense to me, understanding that the FDA approach will work for, particularly commercial entities that are trying to market algorithms. That's probably more suited for them rather than, for example, an institution wanting to develop an algorithm that works for example, Mayo Clinic. We have a unique practice. There might be some things that are unique to us that we need to develop internally. And I think the LDT model is going to be the one that's going to work.
Yeah, I think it actually might be a little messier than people think, or this romanticized vision that all of a sudden these algorithms are going to drop down from the sky and we're going to just, plug them in and begin using them, might be a little bit optimistic. I mean, it could be a little messier than that. And then I think also there should be a verification process involved also, right? So let's say, even if you're getting an FDA approved model or algorithm, you need to make sure that it works in your lab. You need to do your own, maybe not a full validation study, but some sort of verification or something. And is there going to be the possibility of modifying algorithms, do you think?
That's interesting. I haven't thought about, let's say, would commercial entities be willing to have it modified? I think, I actually have not encountered that or experienced that, but having a kind of a base algorithm that can be deployed, but then modified and trained on some of your internal material might be an option for algorithms that, maybe not all of them will work right out of the box. You kind of have to do some fine tuning based on, your stains, the way that you process the tissue, the types of specimens you have, et cetera. So, I think the theme from this is it's going to take a lot of different pathways to get to the point where the end user, like a practicing surgical pathologist, is using a variety of different algorithms developed in a variety of different ways. And like you said, I think it is going to be messy. It just like it's a little messy now when it comes to molecular testing. There's a lot of different ways to do it. IHC, different clones of antibodies that are out there, and no one's using the same one, and different labs using different ones. Unfortunately, I think until things converge maybe towards some final, like let's say there's this fantastic prostate algorithm that ends up being the one that takes over the world. But until we get there, I think there's going to be a lot of different algorithms out there that we're just going to have to, test out, see if it works, see if it doesn't work, develop our own, all those kinds of things. Yeah.
Yeah. Okay. So our problems are not going to be magically solved overnight. But yeah, I think that's a good parallel, between IHC markers. So I think notoriously one that is very messy is Ki67 in breast cancer, right? Where people, I think, intrinsically believe that it's valuable. It's a proliferation marker, but there's just such non-standardization of the methodologies, to actually perform the IHC. There's complete variation in how it's scored, what the cutoffs are. And so there's so much data out there, but it's still really a complete mess in terms of assessing its clinical utility. So I think that's a good point that we could see competing algorithms, right, for various disease states, prostate, breast, colon cancer, and many others.
Yeah, and and I'm coming this from kind of the outsider perspective, just viewing what the landscape looks like from a surgical pathologist point of view, rather than being in the weeds in it, and just seeing there's gonna, well, I've been involved in some commercially, some entities that are trying to make a commercial product, and I've seen that side of it. I've tried to develop some algorithms on my own with varying degrees of success, and seeing that side of it. And I don't think anyone holds all the answers, right? It's going to be an interesting and exciting and kind of a rocky period probably before we get to the point where there's clearly some established algorithms that everyone must have, just like
Right.
there's IHCs that everyone must have, but there's also going to be custom stuff out there.
Yeah. One thing that I think about is that pathology is a unique specialty because, in a sense, much of what we do creates a permanent record, right? The diagnosis is written down and signed off on. The molecular studies are quantitated, and that is the patient's diagnosis that will stay with them and really dictate how they're treated compared to, say, other specialties, maybe where you hear a heart murmur. I heard the heart murmur on Monday. Oh, it was gone on Wednesday. It's back on Thursday, right? And so, in one
Yeah.
sense, pathology is static, right? You're looking at a sample, and right, that is immutable in some sense. It's not changing, but our ability to interpret it and draw conclusions from it is constantly changing. So is there a higher bar? Is there a higher level of perfection or competence that is going to be required for these algorithms? And then I guess the second question is, how do we know when to reassess, right? Because presumably creating these algorithms, building them, doing the studies is time consuming and costly. So how do we arrive at the minimal viable product, so to speak?
Yeah, and I think and I'm sure you've encountered this too, Joe, that when you talk about, AI and pathology, and there's a sense, oh, pathology is gonna be replaced. We're gonna have algorithms that make the diagnosis. And I think that's where, if you're going to have an algorithm that makes a diagnosis where a pathologist is not involved, I think that's when the bar is extremely high, right? Like you said, we basically, whether it's true or not, there's a right diagnosis and a wrong diagnosis in pathology. I mean, there's certainly gray zones, as we all know, but sort of those algorithms that are the ones that are attempting to make the diagnosis and kind of remove the pathologist from interpretation, I think are the ones that the bar is astronomically high. It has to be. Any error is going to be horrible. I think most of the algorithms, and the vast majority, are going to be the ones that are going to be augmenting our pathology reports, and that's where I get more excited about implementing AI. Of course, I don't want to see algorithms replace me. I want to see algorithms make my job a little bit easier, but also make our reports more substantive, make them more useful to pathologists. And I think there the bar is a little bit lower. There's going to be algorithms that are going to be developed where, it might work in 80% of the cases and 20% it fails. Well, for those 80%, hey, it works really good. So do we want to throw it out? No, we just say for those 20% where it didn't work, we just don't report it. To your point, when do we say, oh, it didn't work, and when do we say it did work? And that's going to be where again, a pathologist needs to be front and center evaluating these. And if it didn't work, helping retrain the model, including the data that the algorithm messed up on so it can relearn it. I think it's, algorithms are living things. I don't envision they're going to be locked down. And that's not just how neural networks work. They constantly need data, and they're going to encounter things that they haven't seen, and they're going to need to learn from that. So I guess that's the thing. Like when you think about AI making diagnoses, I think the bar is astronomically high, but I think the vast majority, at least the ones that I'm interested in, and the ones that I think most pathologists would find useful, are the ones that augment our pathology reports.
Yeah. Okay. Now let's talk about some of the work you have done. So you are a GI pathologist, and so maybe tell us about some of the projects you've been working on, or if you can't really get into any proprietary information, just tell us roughly what it is, kind of what the goal was, how you went about doing it. Most important for our listeners, what did you learn? Any takeaways?
Yeah, no, sure. I guess first off, as I've mentioned a few times, I am not a card carrying, informaticist, or do I consider myself an expert in digital pathology? But I think the perspective I have is just, understanding some of the problems that are out there in my specialty, right? So, I've listened to some of the other shows where you talk about how kind of the pandemic, as horrible as it did there was some, decreased workload during that time. So that's when I said, well, let me dive a little bit more into AI and see if there's anything that I can do on my own that would be useful. So I became principal investigator of a colon cancer family registry grant. This is a long-running registry. It's been in existence for over 20 years, and it follows patients with colon cancer. And Mayo Clinic is one of 7 sites around the world that's involved in this cohort. So we have close to 7,000 colon cancers in this cohort, and we followed these patients for quite some time. So I had this great resource that I could use. So I thought, well, this would be something to study. So I've been trying to come up with an algorithm that basically can identify a whole host of features in colon cancer, from tumor grade to tumor infiltrating lymphocytes to the inflammatory cells in the stroma, tumor budding, which is a big hot topic in colon cancer, mucin content, necrosis, all those kinds of things, and see if I can come up with a prognostic score. And having this resource that I kind of fell into of having all these thousands of colon cancers really has been such a boon because, developing AI algorithms, you need tons of data. That's some of the fun things that I think a pathologist that's actively, interested in AI and also has some, knowledge of the disease can really move the field forward, because when it's in the hands of someone maybe who doesn't sign out colon cancer, doesn't kind of know what some of the issues might be, the algorithms maybe aren't going to be as useful to the end user, which are going to be expert GI pathologists in some cases. So
Okay. So practically speaking, I know, just so maybe let's get into the clinical aspects. Colon cancer, I think, is interesting in that grading hasn't really panned out very well as being particularly prognostic. Whereas other features in colon cancer, different to other tumor types. So, for example, in colon cancer, there's these distinctions between left-sided and right-sided. Is it sporadic or is it familial? Is it Lynch syndrome? Is it microsatellite unstable? Right? Is it associated with tumor infiltrating lymphocytes and so on? So there's a lot of other factors that go into prognosis in colon cancer, maybe compared to other tumor types. So I'm just wondering, have you been able to get any takeaways or anything that looks promising in terms of specific features?
Yeah, no, it's really cool. I've analyzed around 2,000 or so colon cancers to date with the algorithm that I've been working on, and extracting all these different features from the colon cancers. And yeah, tumor grade is not really working out that well, but certainly the type and quantity of of stroma, the tumor budding, tumor infiltrating lymphocytes, all those things are strongly prognostic. And it's things that as a pathologist we can recognize. But one of the things that I think AI can do so much better than we can do is quantify these things. We can all recognize what mucin is, but quantifying it in a way is really difficult for us, but pretty easy for a neural network to do. My end goal is to come up with different prognostic signatures, signature 1 through 5 colon cancer, and each one is associated with some molecular alteration, and some of that is panning out. So when I first started, I was really skeptical that this could work. But some of the things I learned, Joe, was, boy, these neural networks are powerful.
Yeah.
It's a little scary. It doesn't take much, and then it starts recognizing things, and you're like, oh my God, this is pretty cool. So I was a little bit blown away, to be honest with you. I didn't expect these to function as well as they do. So that made me even more excited about engaging with this technology.
I think that's something that's kind of emerging in digital pathology, particularly in developing predictive and prognostic markers, because we all know, intuitively, we know there's so much information there, right? And it's interesting, how these features, histologic features, get translated or converted into data,
Yeah.
right? So, but historically, pathologists are limited to a few things, right? They would say, well, it's colon cancer, it invades through the wall, the lymph nodes are involved, the grade is either high or low, and it forms glands 50% of the time or not, right? And that's
Yeah.
pretty much about all anyone wants to hear about it. But obviously, that pathologist is observing so much more. But if you were to say, oh, Dr. Jones, could you tell us if there's tumor budding, right? And there's like all these other things that could be prognostic, but there's not really a good way to standardize it. Or even if that was on the report, like maybe in the hands of an expert pathologist like you might be able to say, to make a comment, but is that going to be scalable? Whereas I think with digital pathology, I think it kind of opens up that possibility.
For sure. I like to think of it as I'm converting an image into math, right? And then once it's in math form, you have numbers, then you can do a lot of things with it. But when we're just looking at it and giving our gut impression, it's a little bit harder to translate that into something. So yeah, we're breaking an image and making it into math, and not that I love math, but then it opens up a whole host of tools that you can use now. That's what made me excited about it, and that's what made me want to encourage other pathologists to not we have to own this technology. I don't think we can let it just kind of wash over us, right? We kind of have to dive into it, even as uncomfortable as it might be at the beginning, for sure.
Right. So, and I think in terms of advancing precision medicine, really what we're after is creating tools. I mean, obviously we want to make workflows easier for pathologists, but the ultimate benefit will be to the patients. And in colon cancer, for example, we haven't done well in terms of saying, so for in stage 2 colon cancer, the question is, does this patient need chemotherapy or not?
Mm-hmm.
Right. And most patients probably won't even benefit. So with stage 2, for our listeners, we're talking about tumor that is invaded into, but not through the wall with negative nodes. So most patients won't get chemo, but a small subset will. So are we anywhere close to developing tools to better predict who's going to benefit from chemo with digital pathology?
That's exactly the question, I'm looking at too. We have about 900 or so stage 1 and 2 colon cancers that I've analyzed so far. And yeah, these kinds of the data that you can get from digital pathology does predict which ones are bad actors, which stage 2 and even some stage 1, which are minimally invasive colon cancers without lymph node metastasis, end up doing bad. But part of this colon cancer family registry, it's multiple sites, and so I'm collaborating with a group in Toronto, and they're with a medical oncologist there who's taking a different approach to AI and more loosely supervised approach, where he's going to feed into a neural network patients who got chemo and those who didn't, and ask the question, what predicts this patient will respond to chemo, more of a predictive biomarker. And that's also exciting. So, we're taking multiple different approaches. I'm doing a more classic kind of segmentation analysis to break the image up into different regions and quantify things. And he's taken more of a different approach, which I think is also going to be quite powerful. So I do think we're on a bit of a, exciting time where we're going to start to use these technologies in the clinical realm. So I think we are getting closer, Joe. I think there's going to be some, prognostic, certainly, and predictive, hopefully, biomarkers that can really tell us, how these patients should be treated.
Yeah. I think that is the holy grail. So, Dr. Rish Pai from the Mayo Clinic. Now, let's tell us a little bit about you just before we wrap up. How did you get first interested in digital pathology, and maybe a little bit about digital pathology program at the Mayo Clinic?
Yeah, sure. I've been in practice for 12 years now, I guess. Mainly focusing on GI and liver pathology, although the practice in Mayo, Arizona, is still general. So I do look at a lot of different things, and I think digital pathology has always been a little bit of an interest of mine. I can't say that I fell in love with it right from the beginning, but seeing the power of being able to look at images anywhere, sharing with colleagues, rather than having to take, still pictures and emailing those. You really quickly realize the power of digital pathology. Even some simple things like measuring, the width of the tumor or something like that. You start realizing the importance. And so I have to say I wanted to be an early adopter and wanted to dive into it. So I did have that interest. I've been collaborating with groups across the world in some cases, and I think having a digital platform that's web-based has been really helpful to be able to collaborate too. So I think just seeing early on the benefits when you can go digital beyond just in the clinical realm, more and more in the research space, but now seeing it come into clinical practice is also quite exciting.
Yeah, I think that's I think many people outside of pathology, so even those little things, like you said, like measuring a tumor. I
Yeah.
mean, if they would have seen a pathologist, a few years ago, right? You look at this thing under the microscope, you draw with your magic marker a line here, you draw
Yep.
here, then you
Then you
pull it
measure it.
out, then you go into your drawer. It's always in your desk drawer. You pull out your ruler and you measure it, and you try to get somewhere in the ballpark. I mean, that's insane when you could just click, click, click,
I know.
on the mouse in a matter of seconds. Yeah. So, I mean, even those little things, it's amazing how far we've come.
Yeah, and so just seeing it's going to come, right? Digital pathology is going to come. So at some point, you just have to, as much as I do like looking in the microscope, you gotta embrace the new tool. And Mayo is really on the cutting edge now. I think they've really embraced, and I'm not leading the digital pathology program at Mayo. I'm just involved in to some extent in Arizona, but I seeing how they're progressing, and it's really a digitizing the practice program here. We really at Mayo want to get to the point where everything is digitized. We're deploying and utilizing AI algorithms, and the timeline that they want to do this is pretty aggressive. I think in the next couple of years, it's going to be to the point where we're looking at things digitally. We're for clinical practice. We're using the tools that are AI tools that are available, and they're helping me support my colorectal cancer algorithm too. And there's hope that maybe if it works out and we develop a pretty cool prognostic and predictive score that we can actually implement that at Mayo. So yeah, it's an exciting time. I think the next couple of years, it's not going to take a long time to get there. I think it's going to be, within the matter of a couple of years. So
yeah, so let's wrap up and just tell us, where do you see it headed? Maybe in 5 to 10 years or beyond that. What excites you about the future?
And I think you've said this with other guests. I really do think, focusing on right case to the right person at the right time, that's going to be really cool. And that's going to be able to be done quickly. And we can really get pathologists doing what they do best quickly. So I think that's number one. And that's kind of in a short-term goal. But I do think in the next 2 to 5 years, we're going to really see algorithms deployed in our practice, and because our clinicians are going to expect that they're seeing algorithms deployed in radiology, they're seeing in cardiology, they're seeing in other fields, and they're going to expect pathology to do that. And I think because we entered the fray a little bit later, when things are a little bit more mature, I think it's going to not take us that long to get up to speed, because it's just using similar neural network architecture and just running it with pathology data. And I think that's going to help us get up to speed pretty quickly. So it's an exciting time, Joe.
Yeah, absolutely. Bringing pathology up to speed. Well, our guest has been Dr. Rish Pai from the Mayo Clinic. We'll see you next time on Digital Pathology Today.
This has been Digital Pathology Today. Please be sure to subscribe. Thanks for listening.